So I'll request Dr. Nihal Adel Hussain to give her talk on OCT biomarkers in DME.
Good morning, everybody. Thank you, Mr. Chairman. Thank you for the introduction. It's always a great pleasure for me.
Can you change the slide, please? Slide us pe kar dijega.
It's always a great pleasure for me and honor to join the All Indian Society meetings in India. Thanks a lot for all the scientific committee, especially Professor Namrata for her kind invitation and general hospitality. To talk about OCT, biomarkers in OCT, this gives me the chance of introduction of how the technology in OCT, as we all know from the time domain to the swept source OCT with its high resolution, gave us the advent of giving the real histological picture of the retina, and this is the recent high definition, high resolution picture that we all see in the OCT. We're giving the details of all structure by structure and line by line, as if a histological section, optical histological section in the macular area, and to focus on the outer retinal layer, which is the very important layers in giving the visual prognosis and the visual outcome of medication for the patient, defining the external limiting membrane, ISOS junction, RPE, Brooks membrane complex, and giving the zones of the myoid, ellipsoid, and the interdigitation zones. These are very, very important to document upon in our OCT reports, and this gives any changes in the pathological change, gives the biomarkers for our extent of the severity of the disease. This is, as we all know, the histology of the macular area, and to overlap this histology on the morphology and the reflectivity of the tissues in the OCT, which gives the integrity of the system, the 10 layers of the retina, starting from the nerve fiber layer, the interdigitations and the molar cell fibers, the outer retinal layer and the reflectivity of the outer retinal layer, which is corresponding and the components of the nuclear of the photoreceptor layer, and up to the RPE layer, which is very, very important, as we all know, for intactness and the light stimulation and the light response. These are the 12 points that we should talk about in any of the OCT picture of the biomarkers, and especially my talk will include in diabetic macular edema, starting with the disorganization of the retinal layer, inner retinal layer, which is the first point that I should like to comment upon, the hyperreflectivity in the retinal and the choroidal zones, intraretinal cyst and the sizes, which is differentiating the severity of the lesions, up to the choroidal vascularity and the choroidal thickness. These are examples of the biomarkers which are the in vivo signs that we should see in an OCT picture, reflecting the severity and the response of treatment. The disorganization in the inner retinal layer is very, very important because it reflects the intactness of the inner retinal layer with the ischemic changes in cases like diabetic macular edema, the hyperreflective zones, and these are degenerated ganglion cell layers and can be differentiated from the high reflective foci of the hard exudation, which gives a posterior backshadowing in this condition, and these high reflective lesions with the high condensation in the intraretinal cyst, denoting the chronicity of the macular edema. And in this case, to see the hyperreflective shadow in the outer retinal layer with, disturbing the complexes of the IS junction and the Brooks membrane choroidal complex, choriocapillaris complex with the high reflectivity, denotes that there's, even after the treatment and the macular edema, cystic macular edema response, there is a visual, bad visual prognosis due to this disruption of the outer retinal layer. And here also is a drill sign, which is the disorganization in the inner retinal layer, denoting the visual dysfunction. And this carries a poor prognosis if it's more than 500 microns, according to the classification. Intraretinal cystic spaces and the shape of the spaces, the reflectivity of the intraretinal cyst itself, and the size of these cystic spaces will differentiate from classifying the condition from small, large, and giant spaces. The intactness of the molar fiber layer, which is the communication from the inner and the outer retinal segments, and this communication is very, very important for the visual prognosis. And if seen disrupted, and also with the disorganization of the inner retinal layer with the cystic spaces denoting ischemic changes. And here is a large intraretinal cystic space with marked thinning of the overlapping inner retinal layer, and also there is disruption and high reflectivity denoting RPE changes in the subfoveal space. All these criteria will denote bad prognosis with treatment and post-treatment. As well as if we'll see the vitreoretinal interface with RPE, with the epiretinal membrane, shadow of epiretinal membrane, and intraretinal cystic spaces with multiple intraretinal cystic spaces, and also there is disruption of the outer retinal layer. This all carries bad prognosis for treatment. And if this moth-eaten appearance with the markedly thin inner retinal layer, and here are cystic spaces denoting ischemic changes, and even after treatment with intravitreal VEGF, improved retinal thickness, but left with an atrophic, markedly thin fovea, and no visual improvement actually in that patient. If there is a subfoveal neurosensory detachment, this carries a good prognosis with the treatment. But here, in this case, there's high reflective deposits in the intraretinal spaces of high oxidation, as we can see corresponding in the colored photography. And this, of course, carries worse prognosis than the upper example, but here the reflectivity and the thickness of the vascular index of the choroid is good, so it's better prognosis in the upper photo than in the lower photo. If there is epiretinal membrane and intracystic edema, even with subneurosensory detachment, but with the treatment, the macular thickness improved and macular edema regressed, but there is still a taut posterior hyaloid with the epiretinal membrane, leading to slight traction on the inner retinal layer. Choroidal vasculature is very, very important in the prognostic and the response of intravitreal injection of such patient, and the vitality of the macular area, as we all know. And to measure the choroidal thickness in this case is very important. And on contrary, this is a thin choroid with markedly thin loss of the foveal contour in a in an ischemic macular ischemia. This is a comparative study in the macular edema and the thickness of the macular area compared to the choroidal thickness. And of course, there is marked improvement with intra-VEGF in cases with thickened choroid. This means the vitality of the structures, especially the outer retinal layer. And in these photos, both of these photos, we can see the integrity of the outer retinal layer, external limiting membrane, and the Brooks membrane, RPE, they are intact, so it carries a better prognosis, though the thickness of the macular area is about 450 microns. Of course, the addition of the technology of the OCT angiogram, this gives a better visualization and more accurate assessment of the vasculature, and even, of course, of the segmentation on layers of the superficial and deep retinal layer with the choriocapillaris. So it compares the three layers of the vasculature in the macular area, not only the overall vascular component of the macular area. And here is a case, even if we are not seeing any macular edema in the B scan, but there is obvious irregularity in the foveal avascular zone with fragmentation of the network, capillary network, in both the deep and superficial retinal layers, which is ischemic maculopathy, though the patient might be missed in cases or even with fluorescein angiography, it won't be that clear due to if there is a slight diffusion of the dye in the late phase or minimal cataract, for example. And this is a more severe case with the obviously very enlarged, irregular, complete loss of the capillary flow in the macular area, with marked thinning in the B scan, which is a severe case of ischemic maculopathy. So these are the biomarkers which might see and should comment upon in cases of diabetic macular edema. As we all know, since the diabetic retinopathy is one of the most leading causes of blindness in the middle-aged population, so biomarkers, and to look for biomarkers in imaging, which provides in vivo assessment of the health of the retina, choroid, as well as to properly, accurately denote the severity of the condition, response to therapy, and the visual outcome of the patient, which is important for me as a doctor and to inform the patient before any treatment protocol. I will have that chance to, of course, invite you all to our annual meeting of the Egyptian Society. It will be on the 7th to 8th of May in Cairo. Looking forward for all to join us, and thank you very much for your invitation and attendance.
Any questions from the audience?
Yeah, Dr. Hassan, just one point. Any of the biomarkers that you look at for deciding what kind of a anti-VEGF or treatment modality you would be using?
Yes, for me, if I will see subfoveal edema and subfoveal neurosensory detachment and good vasculature of the choroid, I will go more for steroid injections. Even if, like triamcinolone alone, it will respond dramatically better than giving anti-VEGF. If there is epiretinal membrane, I will see according to the stiffness of this epiretinal membrane and the tangential traction on the inner retinal layer, if I will balance, if the traction is more, or the cystic edema and the thickness of the edema with the preservation of the intraretinal septa is very important, I will go first for injections, rather than going for vitreoretinal surgery, as of course vitreoretinal surgeons will prefer. But I will prefer to give the chance of injection rather than going firstly for vitreoretinal surgery. Choroidal vasculature is very, very important in these cases because, as I said before, and I'm stressing upon, this gives the vitality of the tissue and the response, because being vital and thickness is good, it means that it will respond much more to the intravitreal injection.
Thank you so much. Thank you.